Okay, so hello everyone. Welcome and thank you for joining us today. So my name is João Pedro Ribeiro. I'm the CEO and one of the co-founders of the PeakMed company. And I have the pleasure to kickstart this webinar, actually the first of our Before Christmas series. So today with us, we have Dr. Levi Fernandes, our Chief Medical Officer, who's also a dedicated knee surgeon and did an amazing fellowship in Hanover with Professor Lobanoffer and Dr. Christian Clay. We have also the pleasure to have Professor Matthieu Ollivier, well known for his love for the osteotomies around the knee and an actual evangelist of the usage of the PSI. So Dr. Levi and Dr. Matthieu will be discussing simple and complex knee osteotomy cases and how PeakMed can actually ease the process for planning for those. But before starting, I would like to highlight two things. So you are more than welcome to leave comments and questions on the chat bar on the YouTube channel, as we'll be answering those throughout the session. And the second one is please have your smartphone ready because there will be some questions throughout the session from these two panelists. So we'll be asking you to answer those. So now I'd like to thank you both, Dr. Levi and Professor Matthieu Ollivier. So I hand over to you.
Okay, good afternoon, everyone. I think there's also a place for good morning and good night for those who are listening to us. So I will start with this presentation about osteotomy around the knee. So we are doing here some case discussing, and I will present the program of PeakMed, which I am the CMO. So in this presentation, we will go through a quick overview of the principles of osteotomy. Then I'm going to do a deformity analysis with PeakMed. I will do some manual planning on the software and some automatic planning as well. And then we'll have some case presentations and discussion. And I have some questions for you during this presentation, and I would like you to use your cell phones or to go to this link so you can answer them during the presentation. So we'll give you some time to join the session about or the questions. The link will be on the chat as well. So if you're joining, if people join during the presentation live, they will be able to access as well. Okay, so the first question that I would like to ask the audience is, how many osteotomies do you do a year? I think there are not still many people joining us, so I'm not sure we'll have a lot of answers for now, but I will wait a little bit. To see if we can get some more answers. Okay, let's continue then. So what's important in the osteotomy planning is the most important thing is the deformity analysis. So if you know where the deformity is, you know where the correction is. And to know where the deformity is, you need to know these angles. So the mechanical tibial femoral angle will tell you if you are in the presence of a valgus or a varus knee. So the normal is between 0 and 3 degrees of varus. Then you have to look at the mechanical lateral distal femoral angle that will tell you the deformity that you have on the femur. You have to look also to the mechanical proximal tibial angle to see if the deformity is on the tibia. And you also have to take into account the joint line congruency angle, which is the angle between the lines that touch the femoral condyles and the tibial plateau. And that we'll see a little bit in the front what it means for us. So when you have a varus deformity, you have to look if it's a femoral varus or a tibial varus deformity. So you have to look at the mechanical lateral distal femoral angle, if it's increased, so you know it will be on the femur. If it's the tibia that is the MPTA is decreased, then the varus is on the tibia, or you can have varus on both bones. And the same goes for valgus deformity. So you have to look closely to those angles to know which deformity you have. Then you also have to take into account the joint line congruency angle. It represents the laxity of the soft tissues, but also the cartilage wear. So if you have a bone compartment in the knee that has a cartilage wear that is significant, the compartment will collapse and it will open on the opposite side. So it's important to take this into account so you can avoid overcorrection or even do an incorrect procedure. If you have a varus knee, but deformity is only intra-articular, it's just because of the cartilage wear, you have an increased joint line congruency angle, but the femur and tibia will be normal. So I would like to ask now if you have experience with distal femoral osteotomy or double level osteotomy as well. You can check the app to answer. Maybe people didn't join for this poll. Okay. Very well, so I think you will enjoy this presentation. So the important thing to know, one of the basic principles, it's not all the varus are on the tibia and not all the valgus are on the femur. So you have to take this into account and correct the deformity on the right bone for a good result. So it's also important to plan, either if it's manually with a software or having someone to plan it for you. So I'll skip this question as well. And I will show you now how to do the planning and the deformity analysis on the software PicMed. So now you have here a case presentation. This is a patient with a varus knee. So what you can do now is you have to measure these angles to know where the deformity is. So you see it's a huge varus and we want to know where it is located. So you can do this manually, the deformity analysis. And what you do in PicMed is you can ask here in lines, you can select a joint line and you can place the dots on the articular surface. And this will give you the axis of the femur. Like this. This is one way to do it. Of course, this takes a lot of time and it's time consuming. So it's time consuming. It's not so friendly. And if you want to plan it, you really want to do it as fast and simple as possible. So what we develop is an osteotomy planning tool, something that does this deformity analysis in an automatic way. And that's what I'm showing you now. So you can go to procedures, select knee osteotomy, select the right side. Now here you can see how to plan the osteotomy, the points that you have to mark. If you have doubts whether you are doing it correctly or not, you can click on this question mark. So now we do the marking as well. You can use this magnifier if you want to help you with putting the points in the right position. So now you just have to follow what the program tells us to do. This will give you all the angles that you need to know before you do an osteotomy. So here in this particular case, you see that the weight-bearing line is crossing the knee joint, passing on the tibial plateau around 10%, 8.9%. So it's clearly a varus. It's 9 degrees of varus in this case. You see there's a little bit of joint line congruency angle because of this aggravated varus, and the deformity comes exclusively from the tibia. Okay. So now you can do it. You can do the plan in a manual setting, or you can do it on the automatic tool. I'll first show you what to do it manually. So you have to cut the image. You see, since this is a varus deformity on the tibia, you can do an osteotomy, an open wedge osteotomy on the tibia. So manually you have to do this, cut the image. Then after validating your cut, you have the point to select where the hinge goes. And then you can gradually opening the osteotomy to the desired angle, okay? And then you can measure it with the ruler and simply do this and see how much do you need to open. Okay, but what we did is that we made a tool that can do this in an automatic way, so you don't have to do all these markings by yourself. So after you have the deformity analysis, at this point, you can click on this wheel here that will do evaluation of the deformity that you have. So you have the mechanical tibial femoral angle, the mechanical lateral distal femoral angle that shows you there's no deformity, and you have the MPTA, which shows you the deformities on the tibia. And then after the measurements, it suggests you the right osteotomy to do, and then you can select between lateral closed wedge or medial open wedge. So then you just have to select the cuts like you see on this image on the left. And now you have the chance to take into account the joint line congruency angle with the formula that Christian Clay explained several times in several meetings. And then you have also the possibility to choose where you want the weight bearing line to go through. You can choose 55, 50, or 62. It depends on the kind of deformity that you have, the kind of osteoarthritis, the grade, and also your own philosophy about this kind of procedures. Then we choose 50%. Usually for this case, it will be adequate. So what it does is it does the cuts by itself, and then gives you also the measurement of the wedge that you need to take or to increase in this case. So the gap opening. So now I'll show you also really fast how in more complex cases it is also very intuitive and easy to do. You have to manually calibrate the image. In this case, something like this. So you can see clearly this is a varus knee. So we do the same thing. We use the tool, knee osteotomy tool. We mark the points to do the deformity analysis really fast. You see there's some cartilage wear, important cartilage wear here as well. Okay, now you have the deformity analysis. This is a varus. As you can see, it's both the tibia and the femur that are varus. So you go to the knee osteotomy tool back here to this wheel. It does once more the analysis of the deformity, and then the measurements. It tells you that the deformity is combined, and then suggests you to do the combined procedure. You can select the type of osteotomy on the tibia, not on the femur, because in this type, it will be a closed lateral wedge on the femur. So now you do the marking points as the image tells you to do. And once more, you get to choose where you want the weight-bearing line to go through. After that, you just click on auto osteotomy and you're done. So like this, the osteotomy is done. You see it's 6 millimeter closed wedge on the femur and the opening of 17 millimeters. You can also add templates to this planning. You can add, for example, a tomofix for the femur, for the tibia, for example, or a new clip plate as well. And then you can take this to the OR. Okay, so now I'm going to show you some cases that where we use the software. So in this first case, you can see this is a varus deformity. The deformity looks like it comes only from the tibia. After the analysis, we can confirm that. It has a low MPTA. The osteotomy tool advises you to do an opening of around almost 15 millimeters. And that's exactly what we did. And that's the end result. Since we are using this tool and we are very confident with the planning that it does, we decided to do a new study where we are going to see if it's really necessary to use an alignment rod during the surgery or not, or you can trust fully the planning. For now, we have some 10 cases already without the use of intraoperative confirmation with the alignment rod, and the results are really favorable because we haven't had many cases with very big deviations. So I'll show you some more. So in this case, you have also a varus deformity on the left. The patient was previously operated on. He had a fracture on the femur, as you can see, also on the tibia. And when he started to complain about pain, he went to a colleague of ours and he did an open wedge osteotomy on the tibia. It brought the tibia to around 92 degrees, 92.7, but it didn't correct the femur. So the deformity progressed and he kept with a lot of pain. So he came to us. It was really painful, but this is a patient that is also very young, 45 years old. So we decided to do a closed wedge osteotomy on the femur after the analysis on the software, and we did, and the patient is doing well so far. And also we have this case, also a big deformity. This patient came to see us for the same reason. The deformity is pretty much almost all on the tibia, but there's a slight deformity on the femur as well. The software tells you to do osteotomy on both the femur and the tibia, and that's what we did, also with a good result. Here, even if the femur has a small deformity, it's really important to correct it as well, because if you don't do that, the tibia would be very, very deformed, and the opening will be much higher. So I have some other cases to show you here that will require your voting if there's someone there to vote. So here, this is a patient, a dwarf patient. He has a valgus deformity. As you can see, it looks like he has deformity on both bones. And what I would like to ask you is, what would you do in this case? Very well. So in this case, since deformity is on both bones, the software suggested a double level osteotomy, both femur and the tibia. In this case, what was done in this patient that was referred to us was only the osteotomy only on the femur. So what we see here is that the femur is well corrected. but the deformity is not completely correct. It's an undercorrection because only the femur was addressed and not the tibia. So this is why important planning. That's why planning the osteotomy is so important. So you can do the correct procedure always. So here is another case: varus deformity in a patient with failed reconstruction of the lateral structures because of instability. So you see he has deformity both on the femur and the tibia, and the software suggested double level osteotomy as well. In this case, the osteotomy was done only on the femur. So what you see here is that the weight bearing axis actually is not so bad. It goes around 45%, but both the bones are with the deformity. So both the bones are at abnormal angles. So what you get in this case is an obliquity of the joint line. And we know now that the results, long-term results of this kind of procedure of obliquity is not so good. So I have one more case here to show you. This is a patient with a slightly valgus knee, 2.5 degrees of valgus. It looks like there's no deformity on the bones. So the question is, what would you do on this case? Very well. And then you see since there's no metaphyseal deformity, there's no need, or other alternatives should be considered. So in this case, there was an tibial distal femur osteotomy that resulted in 12 degrees of varus for this patient, which is not so good. So now I will end the talk to Matthieu Ollivier, so you can talk about this, about your experience with the software. Matt?
Thank you, Levi. Thank you for the talk and the cases and everything. I mean, we are touching a very important question in the osteotomy. You know that it has been my patient for a year, and we both have been lucky to have to meet with the Lobenhofer team, Christian Clay, and all those guys that helped us to get to another level regarding our understanding of osteotomy. And I used to say to my resident that the 50% of the job should be done before opening the skin of my patients. And why planning is so important, it is because you have high chance to completely miss your surgery if you're not do a good planning. There is two citations, one from a French writer, which is Antoine de Saint-Exupéry, which used to say that a goal without a plan is just a wish. And the other one from Benjamin Franklin that say that if you fail to plan, you're playing to fail. And I think those two sentences should be behind you in any osteotomy surgeries. Why it is so important? Because varus, for example, in the left case here, is a very complex disease. We don't know to date where is the etiopathology of the varus arthritic knee, but I do think, following my research in the last years, that femoral varus is more detrimental to tibial varus to create medial arthritis of the knee. So I would say in most of my cases today, there is a small amount of varus hiding in the femur. And if you're looking closely to that, and the more you dig into osteotomy, the more you want to do double level osteotomy. This is a case of mine 3 months ago. This guy came to me for a bowed leg and asked me, I want this to be corrected because I got meniscus injury now. He is a professional cop officer. And I said, okay, but if I'm just following the anatomy and the basics, it will be a double level osteotomy. And the guy told me, we should do the two legs at the same time. So it was 4 plates in a single day. It took me some time, but I mean, this guy is very happy now to have his leg completely straight. And if you do all in the tibia, which is in France, sadly, very, very common. Most of the surgeons shoot all in the tibia, whatever they found, whatever it is. your result will be connected to a very high rate of joint line obliquity, which is probably tolerable for the first years, but will lead to a very high level of revision, TKA conversion, and impair outcomes after 2 to 5 years. And we all know that. We are just tolerating joint line obliquity because we are afraid of jumping to a double level. But when you start being confident with your femoral osteotomies, there is no question. And every surgeon that is confident in femoral osteotomy will say, of course, my result of DLO are better than my big HTO that I was performed in the last 5 years. And all of us are fully agree that DLO is probably the new way to perform osteotomy in young athletes and young patients. What also it is important to plan, because it's everything is mathematics and biomechanics in osteotomy. It's probably the first surgery of the orthopedic history. The Greeks were doing osteotomy some 3 centuries before Christ. So, I mean, it's the first orthopedic surgery. We need to respect it. It's mathematics, how to convert angle into millimeters, how to convert weight-bearing line from a point A to a point B. We have fantastic jobs made by the pioneers, Fujisawa, Mikulich in the late 19th century. Those guys gave us the heritages with everything is based on that. So go read the papers. You will see that tons of things can be done to switch the weight-bearing line to a point to another point. FACTAM is a rule of my friend Ronald van Leeuwarden. This is, I think, one of the most important messages I have in my life. Femur always close, tibial always medial. This is how when you decide to plan something, you will discover that the more you do osteotomy, the more you close femur and you do medial opening or closing wedge, because it will give you the best results. Finally, find the ideal plate. Thank you, Levi, to mention New Clip, which is making in France awesome work with new plates, new design, smaller profile plate to have lower outward removal rates. But anyway, plate is the last of your consideration. Osteotomy is converting math into millimeters, and this is why PICMED is at the top of the pyramid of planning today, because what I'm providing you is being able to see very clearly where is the deformity is lying. Second, how to switch a point A, weight-bearing line on the tibial plateau, to a point B. Do whatever you want, but probably close femur and medial osteotomize your tibia. And finally, do your planning with the plating position at the end. Finally, be aware that when this is done, the planning is done, the intra-op parameters that you can play with are only 3. How do you cut? How do you insert the wedge? And how do you protect a safe hinge to rotate the upper metaphysis into the distal metaphysis, even for the femur and the tibia? This is the only 3 things you can control during the surgery. Then you will fix, then you will probably fill a gap if you create an opening wedge, for example. But cutting, wedge, hinge are the 3 only things you can do inside of the surgery. So when you have your pre-op planning, you need to have in your mind, where is my ideal cut, where I'm supposed to insert my wedge to avoid any, for example, slope modification in opening wedge osteotomy of the tibia. And finally, where my hinge is supposed to be located to avoid any sagittal movement of my femur or my tibia. Next slide, please, Levi. And I will show you why PICMED is so important in my life today. Because of my expertise, I received tons of questions from many surgeons all around France and even around the world. And they all are afraid to jump into DLO. And they're asking me, what will you do? And this is a case from a friend of mine in Tours, which is a city near from Paris. And of course, it's a DLO planning. But this guy was not so sure. So I just jumped into PICMED. And so the measures are not calibrated, because it's just to show him that the computer will answer the question better than I do. So I do exactly the planning that Levi showed you some minutes ago. Just shoot to my point, tibia, femur, ankle, and I mean, this is the 30-second job to answer a very big question. So as you can see here, I record this with QuickTime. I have my ankle here, and then ask for the measurement, and the measurements were very clear. So this is done, and you can see that there is a wrong mechanical lateral distal femur angle, a wrong medial proximal medial tibia angle 2. The joint line looks okay, and the joint line ubiquity was wrong. And I asked the software, what should you do as an artificial intelligence? What will you do? And of course, the answer is double level osteotomy. So I select a medial closing wedge because, as you know, medial opening wedge on the tibia, because I don't like to go too lateral on the tibia now. And I asked the software to create the correction I was intending to do in this guys. And I mean, it's done. And this is why I sent to my friend and I say, it is not me that recommend the double level osteotomy. It is even an artificial intelligence. So if you want to shoot for a 60, 55, whatever you want to do for the passage of the Mikulish line onto the Fujisawa point, but then the jump was done. And the measure are not real, but because it's not calibrated. But anyway, the answer was given by the software and not by me. And my friend said, okay, I get it. I would go for a double level osteotomy because of this software. And I think it is the biggest game changer I saw in the last years, maybe associated with PSI concepts in high tibial osteotomy. I'm sorry, but it's not on the same subject. But then you have the answer, and I can tell you how many. I received 3 different questions from Nuclip today to help surgeon in the US, in England, and in Italy to have the good correction. And my answer was exactly the same thing at the same time. I'm just quick timing my planning with PicMed, and I have the software to do it. I'm fully confident on what will come out of the software. And even if you are starting thinking, you know, if you go to the software, you already know that you're wrong to do a hole in the tibia or hole in the femur correction. You're starting to understand that the anatomy of the pathological varus and valgus are more complex than just one bone abnormality. And then you go to the more and more you dig into double level osteotomies. Now we have time to discuss, I think, Levi. Huh?
Yes.
We'll probably have some.
Thanks for your words and your.
Thank you for this anyway. I'm very enjoyed discussing this with you.
Okay.
Wow, anything?
Yeah. So while we first, thank you for this amazing presentation and case discussion. So while we wait for some questions from the audience, throughout the presentation, I had one question in the back of my mind. So how do you usually include planning in the overall process? So typically, would you plan for the whole week, for the whole month, or you would plan on a case by case so you have time to focus on the specific case before jumping to the next one?
I will take it first because.
Okay, go ahead.
So my answer is I'm always do at least 3 plannings for the same patients. First, in front of him, when I have the long axis, I say, this is when I would going, this is, you can say, this is what the software is saying. This is what a robotic intelligence is saying, double level osteotomy or high tibia or whatever. Then at the end of my clinics, when I have like, say, 5 different cases to plan for, let's imagine a week, I'm redoing everything and integrating this into my pre-op recommendation for the nurse. And then the night before the surgery, I'm redoing everything and I'm double checking the height of the opening, the height of the closing, and I'm taking a picture of this on my cell phone, which will be one of the things I will have into the OR at the end to have a complete correct. So I'm double checking the side, I'm double checking the plate, I'm double checking the graft if I need it the day before. 3 different plannings. Hopefully the same, but you know.
Yeah, no, that's great. What about you, Dr. Levy?
Yeah, actually, this is one of the things that I like about the software is that if you have the images and if you have the patient in front of you, you can clearly show him what is the plan for him. So you can get up of the chair and say, look, when you put your foot on the ground, your mechanical axis is going through the medial compartment more than the lateral one if it's a varus. And if you put more weight on it, it will wear faster. So what we want to do is to reposition this weight-bearing axis into the middle of the joint or a little bit on the lateral side, so the medial one can be relieved. So and then after that, after showing him how it is that he walks, I do the planning on PeakMed, and I can show him in a minute or less what is going to happen to him if he chooses to go through this operation. And also you can add the plates as well. And then usually you can go back and get the case you had, the previous case that you had to show him. Also, this is the first time I planned the surgery. Then at that time I have an idea of what I'm going to do. And of course, after sending the patient home and planning the day of the surgery, the day before, I also repeat the plan and I do the same thing. I print the final correction that I want to make and I take it to the OR with me. So it's of course at least 2 or 3 times that I plan. I never plan. We plan as the cases are coming up and usually save it on the file of the patient.
No, that's good. That's good. That's at least that's what I thought, but I just wanted to make sure. And another topic that is typically raised is the kind of surgeons who feel uncomfortable doing osteotomies because they are not used to, or because they have just a few cases a year. So they would typically change or select a different approach for the patient. So why do you think those surgeons feel uncomfortable with the procedure, so with the osteotomy around the knee? And how do you think that a PeakMed would be useful for those surgeons who are either starting their career or they are starting at least to engage more with osteotomies around the knee?
Well, I can take that one first if you want.
Go ahead.
Well, I think the most important thing for surgeons is actually to, if they are afraid, which is normal, I think they should do what I did and what most people did. You have to learn from someone. And what you have to do is you have to visit someone that is confident with the procedure, that knows the tips and tricks. You take them home. And then when you are, what happened to me is that when I visit those surgeons, in this case, Professor Lovanoff and Dr. Christian Clay, the first thing they told me was how did they plan the surgery? They plan it, of course, in a different way, or not because the PeakMed wasn't available, but they showed me the principles and they showed me how to do it in the OR. And then when I came back, what I needed to do is what we see is that people even after visiting surgeons have some difficulty in the planning. Okay, the surgery is not a problem because they are used to lateral incisions, to medial incisions, to cutting the bone, to use the saw. So that part is well understood after you visit someone. The hardest part is when you get back and you need to decide. The decision of what to do is what is bringing more conflict to the surgeons. So at that point, I felt that if we did a basic tool that you just have to press a button to go forward in the computer, and that computer tells you what to do, this would be a great help for surgeons who want to do osteotomies the right way, but just have difficulty with the decision of which osteotomy will be the best for the patient.
I will answer by my side. I think Levi said everything. The problem with osteotomy is that the master of my master, Professor Jean-Manuel Aubagnac in my department, was doing like 500 osteotomy in a year in the 70s and 80s, because there was no other options. And at the beginning of the 80s, the TKA and the UKA and this kind of procedure happened in the world, and was so successful for good reason in very bad arthritis scenarios that everybody forgot about osteotomies, and the option from osteotomy or or any kind of prosthetic replacement, switch to medical treatment versus TKA. So if you face a patient of 45 or 50 with early arthritis, but not a real bone on bone, your two options were first to do a TKA anyway, which was bad, or second, wait for 5 years with injections, rehab, whatever it is, to have a real arthritis and do the TKA. This lasts for 20 years, except in Germany and probably Netherlands, where people, and in some part of Italy, where some people still promote osteotomy and keep the level of science and everything and plating development and engineering and whatever at the very high level. But except in these zones, everybody forgot osteotomies. The problem with TKA then is that people were involved into TKA surgery for reason like, I want to return back to sports. I want to still run again. I have a very bad cartilage and meniscus injury, and they get TKA for that. And of course, the results were awful. So people will return to osteotomy in this kind of small areas and blank space in between TKAs and medical treatment. But the results are so good after osteotomy. If you have the good indication, the good planning, the good surgical technique, the results are so awesome, to be honest, that now we are invading the high-grade arthritis, the very young with meniscus injury, the unstable knees. And now osteotomy is again mainstream, and you receive email from patients, you receive email from some other surgeons saying, lucky me, I met you because you teach me how to do osteotomy, or you provide me an osteotomy, and now my knee is doing okay. You told me it's maybe only for 10 years, but 10 years is a very long time frame at 45. And so this is why the stream is going into more and more osteotomy today. It's not a really complex surgery. To be honest, it's not. It's just that nobody around you knows to do it properly. And just like Levi said, you need to travel to meet surgeons which are doing 50, 60, 100 osteotomy a year. We were discussing that probably the number one volume in the world is Lukas Sanak in Germany, which is doing 300 a year. And those guys are machine in terms of osteotomy. So if you meet Christian Clay or Lukas Sanak, you will see that they can do osteotomy in an incision which is the last phalanx of your thumb. And they do it perfectly. And if you meet those guys, your fear regarding the complication and the everything around surgery will just disappear, because you will say, okay, in fact, there is not so big thing to cut the posterior cortex of the tibia. I have probably a saphenous vein injury during the incision, but if I protect correctly the posterior neurovascular bundles, nothing bad will happen. And that's true. So I have a very low rate of complication, and I'm doing 100 osteotomy a year. So the more you do, the more you get comfortable. But to start, you need to start with somebody which would teach you the basics. Otherwise, you miss your planning, you miss your surgery, and of course, the patient are missing the good outcome they were supposed to have, and the expectation are not they're not meeting expectations.
No, I think that is fair. So thank you for that. So just one last question, and now it's more a curiosity on our side before we wrap it up. So what do you both think would be the next thing on osteotomy surgery? So we discussed today planning, we discussed today PSI. So what do you think will be the next big thing around, or for, in this case, for osteotomies around the knee?
I will take it.
Go ahead.
Because Levi will say something wrong. No, I'm kidding. I will say that.
Go ahead.
We discussed that just before the opening of the session, and we discussed robots. And I was saying to Levi that if robot game are coming into osteotomy, I would say that I was wrong for many things in my life, because I'm not sure that there is any business model behind osteotomies associated with robots, but probably there will be one day. But I would say that probably the future is new technologies, because what we are doing today with PSI is even Nuclip or Materialize, which is the two main brands around this, already crazy. We are making derotation, free planar derotation, valgus plus sagittal plane correction at the same time with the same, in a very easy manner today. Things that would take hours in some years ago to me or to anybody. So I would say that this is one thing, the precision connected to new technologies, which are probably robots or virtual reality associated to surgery. But to be honest, I think the next big thing for osteotomy will be the rebirth of this surgery as the number one or number two in healthy and early arthritic patients. Because today there is too many surgeons around that do meniscectomy for no reason in degenerative changing knees. Too many people going for PRP or stem cells. I mean, let's return back to basics. If you have an abnormal metaphyseal deformity in the tibia or the femur, the best option is to correct it, to change the weight-bearing parameters on the top of the tibia. Point. Add stem cell if you want, but be clever enough to see that mechanics are stronger than any phantasm around stem cells or PRP things, or whatever it is, cartilage graft or whatever. Mechanics are your enemy. If there is wrong mechanics, the first step is to correct this wrong mechanics into something more accommodating for the cartilage. So I think the next step is the rebirth of osteotomy to be what it is, which is one of the biggest game changer in your patient lives.
Levi, do you agree with that?
Yeah, for me, actually I was hoping that you stopped when you talked about robots, but actually I think that you're absolutely right. I think we don't have to look so much to those technologies that are being used especially in some spine surgery as virtual reality or robots in total knee replacement. I think it would be great, and I think we are working on it, and especially PicMed is working on it as well with the AO group, so we can provide educational support, so we can deliver osteotomy to more surgeons so they can deliver it to their patients. So I think that's a good mission to have, and a bright future or something to look to in the future, to look up to, would be to osteotomy being more worldwide used, and also so we can gather each time more evidence about its use and its clinical results all around the world, which are important to support all the work that we are doing in small centers or big centers, especially or mostly around Europe and in Asia as well, and Korea as well. So that would be my wish for osteotomy around the knee.
I'm buying it.
And I think it's a great way to end this session today. So yeah, lastly, I would just like to thank you both again for your availability today. I think it was a very good session. So we discussed a lot of topics, and especially new technologies, because that's why we are here today. So again, thank you both. Thank you for everyone who attended the session today, and we'll see you in the next one. Take care and stay safe.
See you soon, guys.
Thank you. Bye.
Yeah. Bye.